these are important measures to take together. Now, in regards to the new variants, let me give you the worst case. The worst case was published over this weekend. An expert group called the SAGE group that's advising the British government. They believe that we are nearing the verge of developing variants that may completely escape vaccine-induced immunity. That's one end of the spectrum. I don't see that yet, but at least in one in vitro test tube study, the Lambda variant probably evaded even more than Delta vaccine-induced immunity. So these are serious issues. We are going to continue to develop variants as long as we have unvaccinated people who are getting infected.
Good. So basically, like it says, if we get enough people vaccinated, is that enough to stop a widespread outbreak of these variants? And the answer is yes.
I think the answer is yes, but since we now are dealing with a different variant than a year ago, that level of population immunity is higher than it was. If it was 70, 80% back a year ago, it is probably 90, 95%, something in that order. And by definition, we cannot get there based on the number of people who are rejecting vaccines. So the most realistic picture of this is we have let this get to a point where we can no longer talk about we're going to eliminate the pandemic. We're going to now be transitioning scientifically into what does it mean to live with this virus as we do with influenza.
Mm-hmm. Thank you. Another question here. Some parents are holding off on vaccine because their child, young teen, already had COVID during this last school year. How long should school-age kids wait, if at all, to get vaccine if they already had the virus? How long do antibodies last in young people? Is that different from adults?
So this is a great question. We do know after you get COVID-19 vaccine, COVID-19 infection, there is likely a period of time, and this varies from person to person and also depends on other factors like your overall health and the strength of your immune system, that you likely have some sort of protective antibody, which protects you from getting infected again. The length of this is still not clear, and as I mentioned, probably there's some variability to it. And so we would not recommend anyone rely on that protection from their previous infection as their primary method by which they're protecting themselves from future infection, because that protection likely does, and we have seen people get recurrent infections decrease over time. So vaccination is still the most effective way to get protection from this without having to go through the downsides of getting natural infection itself. Vaccination is the safest and most effective way to derive protection. In terms of time frame for waiting, if you've had COVID infection and getting a vaccine, there is not really a minimum time frame. You may recall back when vaccines were in short supply, there was some recommendations that you could delay vaccination for 90 days if you had been diagnosed. That was primarily because we had to prioritize people who had no immunity at all, but that's no longer the case. And we would definitely recommend, even if your child had previous COVID-19 infection, that they do still get the vaccine if they're over 12 years of age.
I can maybe add a bit of the adult perspective there. In some of the adult studies, we see infection at a mean of about 100, reinfection, a mean of about 116 to 124 days. So I would absolutely endorse that as soon as we could offer vaccination after reinfection, the better. In fact, the studies from an immunogenicity point of view showing that having at least one dose after a vaccine after previous infection is really superior immunity. We're not recommending people go get infected, but it counters the myth people have that oh, I've had it a year ago, I don't have to worry. This is a different virus than a year ago.
Okay, thank you. Thank you. And here's a follow-up question, and I think you might have answered it, but I'm not sure. Evidence suggests one shot is sufficient in people with natural immunity to create the equivalent antibody response of 2 shots in immunologically naive people who were not previously infected. Thoughts on that?
The questioner is correct.
Okay.
That when we look in the test tube, measure antibodies, et cetera, that they infection plus 1 dose is probably superior to 2 doses of vaccine. Now, there's controversy around that. And there is no recommendation for just 1 dose. The recommendation continues to be 2 doses even after previous infection.
Okay.
Just want to make that clear.
Yeah, no, thank you for doing that. I appreciate that. Okay, so I think I have gone through most of the questions. I know some of them looked pretty similar. So I might have skipped over a couple just because they tied into masking in schools and stuff. But journalists, if I have missed something, go ahead and put it in the chat. We have about 10 minutes left. I would also welcome, if it's easier to unmute yourself and ask, you could do that. Just let's be polite not to talk over each other, because I think we have about 40 some participants on today's call. Oh, I have a question about boosters. Hold on. Sorry. Has to do with the who. Give me just a minute here. I saw it in here. Okay. Given the news today that the World Health Organization recommends holding off on vaccine boosters until September to give more countries a chance to vaccinate more of their populations, can you give us a brief overview of where we stand on boosters?
So as people may know, and this is for adults, not for children, but the country of Israel and just this week, Germany, are moving toward a booster dose for immunocompromised and elderly patients. My personal opinion is that that's jumping the gun a bit. I don't think the data support that at this point. With more and more time from last dose of vaccine, we may see an issue there, but there's a subtlety here. There's the use of the so-called late booster, which is getting a 3rd dose of what you got previously, versus a variant-specific booster. You can probably over-immunize to the detriment of the individual. In other words, if you train and train and train the immune system to respond to the Wuhan strain-based vaccine, and now you present the immune system with a radically different variant, you may actually decrease protection in the ability to offer a variant-specific vaccine. So we have to be mindful of some of the nuances of trained immunity and immunology here. Nonetheless, the manufacturers appropriately are looking at the role of a 3rd dose so that we're prepared if we need it, and looking at the role of a variant-specific, quote-unquote, booster. And I think that's appropriate, but I think premature. The one area I would carve out would be to say we have certainly seen in studies around the US and the world that solid organ transplant, and by extension, probably very highly immunocompromised other patients, don't develop the same level of immunity and vaccine efficacy after 2 doses. And that may be a place where we first start with booster doses.
Okay. Okay, thank you. And now I have a lot more questions, you guys. Let's go down the list here. Let's see here about outbreaks in schools this fall. Do you think there will be widespread outbreaks in school? And then also seeing that numbers are already high this summer, is there a potential for flu spread coupled with COVID, especially concerning? I don't know, Dr. Rajapaksa, if you want to take the school one, if we're concerned with outbreaks in school this fall, and then we can go on to Dr. Poland.
Yeah, so what happens in schools seems to mirror what's happening in the communities around them. And so I think that's what's going to determine how many cases we're seeing in our schools. if we can implement all of these measures and drive down community spread of virus, then that makes our schools even safer for our kids. We do know that schools did not seem to be amplifiers of virus transmission within communities. So they don't seem to drive spread in the community. It seems to be what's happening in the community is reflected in the school itself. And so we do know that it is possible with all of these layered measures to get kids back in school safely. I think whether or not we see outbreaks depends on what we see with community transmission and how closely and how well we use the measures that we know prevent transmission in school settings.
Yeah, and I think we're going to do the same experiment again. We're going to see that in schools that do use masks, we're going to have low rates. In schools that don't use masks, I think we're going to see higher rates.
Thank you. Let's see here.
Can I also just piggyback off of that question? Because we've talked a lot about COVID-19 vaccines, but not so much about other routine childhood vaccines. And we know that children have fallen behind on many routine childhood vaccines, especially importantly, measles, mumps, rubella vaccine and the whooping cough or pertussis vaccine. And certainly one of our concerns as pediatricians is seeing outbreaks of those infections starting to occur as kids start to gather together and mix more and travel more. And so even though there's no COVID vaccine available for kids under 12, right now, we do highly recommend if you have a child under 12 years of age to reach out to your primary care provider and make sure that your child is fully up to date for all of their other routine childhood vaccines before they go back to school as well, because other infections are still out there and we need to continue to do whatever we can to prevent those as well.
Really, really important point.
Yeah. And do we know when a vaccine will be ready for kids 12 and under? Is it months away or years away?
Months away. In fact, the greatest likelihood is that sometime winter of 2022 that we'll have vaccines at least down to age 5 years. Now they're looking at 5 years to 6 months, but as you might imagine, as you step down each age group, there are more and more stringencies associated with that.
Yeah, it's good. Good to be safe, right? Given that natural and vaccine-induced immunity is likely superior, is there a case to be made that a mild asymptomatic breakthrough infection is essentially a free booster, providing enhanced immunity against future variants?
So this is an interesting perspective because in the US, we take a me approach and other countries take a we approach. And the question somewhat belies that. In other words, for you, if you knew you were going to have an asymptomatic infection, that might be good from an academic immunologic point of view. For everybody around you, that's bad news. That's bad news because we know that asymptomatic people can spread, maybe not at the same level that somebody who's floridly symptomatic and coughing and hacking, that kind of thing. But you actually endanger other people when you have asymptomatic infection if you're not taking precautions.
The other thing I'll add from a pediatric perspective is the multisystem inflammatory syndrome in children that we have seen as a rare but serious complication of prior COVID-19 infection. Some of those children have their initial COVID infection was asymptomatic or very mild as well. And so even though it is rare, it can be a life-threatening illness if it develops. And so that's another reason why vaccine-induced immunity kind of gets you to immunity the safest way rather than dealing with natural infection.
Yeah.
Right. All right. Going back to masking, someone asked if N95 masks come in child sizes. Are the masks made that small? Also, what fabric would you recommend if N95 masks are not available? Also, what stories would you like to see reporters cover about COVID-19 Delta in schools? Is there an untold story? But let's go to our KN95 masks. Kind of talk about those and fabrics again.
So I will say generally most masks, especially kind of the more medical quality masks, have been designed for adult faces and face shapes. They generally come in a variety of sizes. I have not specifically looked for manufactured KN95 in a child size, so I don't actually know the answer to that question. But I will say the challenge with some of these masks, and in the hospital setting, we've had to wear the N95 masks occasionally for patients having certain procedures, is that they can be, they're generally not as comfortable to wear, especially for long periods of time. And children, especially, I think, would struggle with that. They're generally a bit harder to breathe through and a bit more constricting. And again, the most important thing is that they are wearing a mask that fits them properly, and wearing a mask that's uncomfortable for a full school day is likely not a realistic expectation for most children. And so I think the comfort factor has to be an important part of the consideration here.
Frankly, I don't think I can wear an N95 all day. I haven't tried, but after a few hours, I want it off.
Yeah.
Maybe the other point to make is that and while there are a lot of nuances with this, it depends on what kind of cloth mask, how many layers, and whether there's a filtering layer in there. So some of the single cotton fabric masks you see people buy in the store that are gapped around their nose and gapped around, I don't think those are very effective at all.
Okay. No, good advice. Good advice. Thank you. Couple questions here. What are we hearing about the spread of the virus in rural areas, including schools? Do either one of you have some information about that? Okay.
Yeah, I mean, you know, there's a couple of factors in regards to rural versus urban. The advantage of rural is that you don't have the congregating in the workplaces, stores, you know, et cetera, that you do in the urban. But being in an in a rural environment seems to be closely associated with immunization rate, and those are generally lower. And that's the real factor, I think.
I was on mute, sorry. One last question from Robin Aubrey, and this might have to do with the response about the boosters. She's asking, will it hurt if someone gets a third shot by their own accord? Could it harm?
Well, so we don't have in adults, we don't have a large database on safety of a third dose, and we have virtually no data on efficacy of a third dose. And this is something that's a real problem as we talk about COVID. People jump to what intuitively makes sense to them. Oh, more is better. Well, immunologically, that may or may not be the case. And as I explained, you train the immune system by what you show it in a vaccine. And so giving repeated doses and then exposing something to a very different S protein may, in fact, not be to our benefit. Okay. So a lot of research yet to go into giving a really clear answer to that excellent question.
Great. Thank you. I have a lot of thank yous from media on the chat for both of you. I want to extend my thanks as well for taking time to do this. We are at time, and I don't want to keep you much further from your other activities. But journalists, if you need me, go feel free to email me, and I can get questions to our experts. Otherwise, thank you so much, and we look forward to maybe hearing from you again.
Thanks.
We'd rather not, but if there's other things, we'll ping you. All right, take care.
Be safe. Vax and mask.
Yes. Thanks.